Okay, good evening, everybody. Thanks for joining our teaching this evening. Today we will have a very interesting topic. It's atrial fibrillation, a very common problem faced in the ED and the wards. Will be presented by Dr. Rawia Mustafa, acute medicine registrar in Blackpool Hospital. The session is recorded and the feedback forms will be distributed as usual on the group, hopefully tomorrow maybe. And the microphone to Dr. Rawia whenever you're ready.
Okay. Hello. Good evening, everybody. Today we will have a short talk about atrial fibrillation. I choose to talk about this topic because it's really very common. Almost all types of doctors can be faced by patient who is having atrial fibrillation in the wards, in the theater, in the emergency department, in the ITU. So to have a short talk about it and stepwise approach to how to manage and how to approach the patient is very an important issue. So first of all, I will talk about the definition of atrial fibrillation. It's one of the forms of a narrow complex tachycardia. So by this definition, I'm talking about 2 points. The first one is narrow. It means that the QRS complex is less than 3 small squares. And tachycardia, it means that heart rate should be 100 and above. Pathophysiology of atrial fibrillation, there is a chaotic, irregular atrial rhythm. It starts at 300 to 600 beats per minute. So the atria are going to fire at different points, at different rates, at different velocities, and almost all of the atria is going to be active. Some of those impulses are going to be connected and transferred through the AV node to the ventricles. Some are not going to be transferred. So the AV node responds intermittently, and hence there is going to be irregular ventricular rate, but definitely it's less than the 300 beats per minute. Overall, atria are not bound by ventricles are not bound by atria. Each one is going to work by its own way. Generally, having a patient of atrial fibrillation, whenever you are faced by a patient of atrial fibrillation in any area during medical practice, put in mind what type of atrial fibrillation is this, because management is going to differ slightly. There are some things that we can add in certain patients. So some patients may have paroxysmal atrial fibrillation. It comes and goes for up to maybe 30 seconds or up to 7 days. Those usually the patient is going to prescribe what he or she is having. Then we have persistent atrial fibrillation, and this needs to be looked after by the doctor in order to find the definition. Either the patient is, or if it's less than 7 days, but having symptoms enough for the patient to go for cardioversion. And then the permanent atrial fibrillation, which is the one which we face most during our medical practice, because many patients, we found them having atrial fibrillation. We don't know for how long they have atrial fibrillation. So permanent ones are the ones who fail to terminate with DC shock, or terminate but relapse within 24 hours, or those with long-standing and no indication for DC shock for them, but nobody knows when did they start to have atrial fibrillation. So having an irregular rate of, for example, 80 beats per minute, if by chance patient was prepared to go for hip replacement and found to have atrial fibrillation, which is 60 or 70. This by itself is not a big issue because the patient is not in active state now of having acute atrial fibrillation or having decompensated heart failure or decompensated rhythm. Why we are concerned about atrial fibrillation itself? Because it's a risk factor for having stroke and thromboembolic disease. So even if the patient is rate controlled, we look for other complications of atrial fibrillation, and this is why we need to treat atrial fibrillation, and that's going to be part of our talk next. So what are the causes? Most of the cases are idiopathic. Just patient presents and they are found to have atrial fibrillation. But on the other hand side, there are clear associations and causes of atrial fibrillation. Definitely the heart is going to be the origin, having ischemic heart disease, heart failure, rheumatic heart disease, or congenital heart disease. All of those are risk factors and strong associations with atrial fibrillation. Non-cardiac causes, acute confusion, acute infections, diabetes, electrolyte imbalances, thyrotoxicosis, and pulmonary embolism. And sometimes, especially for the paroxysmal types of atrial fibrillation, coffee, excess coffee and caffeine drinks, alcohol, which we know as holiday heart syndrome. Usually patients present here on Sunday having an acute attack of atrial fibrillation, smoking, and some medications like salbutamol, which are the beta agonists. So whenever we are faced by a patient of atrial fibrillation, now we have some idea about what might be the cause, even if it's idiopathic, some idea about the time. All of those information should be get by taking history, not necessarily to be a detailed history, but some points of some questions should be asked to the patients, and then I will have some idea about it. Putting in mind that I'm dealing with the atrial fibrillation because I want to decrease the risk of the patient having a stroke or other thromboembolic diseases. So how do I manage? There are aims when we are managing atrial fibrillation. The first one is to decrease the symptoms and complications. Again, this is effective if the patient presents with heart rate of 100 and above. But if the patient is 80 or 60 or 70, it's not a big issue. And the management depends on acuteness of the symptoms, hemodynamic stability of the patient, presence of underlying cause, and the presence or absence of heart failure. Each one of those 4 points will have its impact on the management of the patient. So, first of all, if I'm faced by a patient who is having atrial fibrillation for less than 48 hours, and the patient is hemodynamically unstable, very common scenario, for example, a patient is admitted for pneumonia or admitted for hip replacement, knee replacement, and the ECG during admission time, there was no atrial fibrillation. All of a sudden, the patient developed high heart rate, News score was high, and was called by the nurse. ECG was found to be in atrial fibrillation, and the patient is having hemodynamic instability in the form of systolic blood pressure less than 90, pulse rate more than 150, shortness of breath, syncope, chest pain, and or loss of consciousness, or even deterioration of the level of consciousness. All those are signs of hemodynamic instability. So I will approach the patient ABCDE approach. When I reach at the C, I will have the ECG at my hand. Then this patient is for urgent cardioversion, urgent DC cardioversion, without waiting for anticoagulation. If unavailable, the DC cardioversion, if it's unavailable for any reason, try medical cardioversion in form of amiodarone or flecainide. And definitely, there should be treatment for the associated illness, which was maybe the underlying cause for the acute event to develop. So, whenever I'm faced with a patient with acute atrial fibrillation less than 48 hours, and the patient is hemodynamically unstable, having systolic blood pressure less than 90 or even MAP less than 60, pulse rate more than 150, shortness of breath, syncope, chest pain, or loss of consciousness, is going to be an ABCDE approach, urgent DC cardioversion, or medical cardioversion if the electrical cardioversion is not available. And I don't think this is common. The common thing that the cardioversion, the DC fibrillators are available everywhere in the hospitals. The second category, if the patient presents with atrial fibrillation but hemodynamically stable. Again, this is a common scenario. So if the patient, the same scenario presented with pneumonia or for any operation, and the first ECG doesn't show, the first ECG doesn't show any signs of atrial fibrillation. So this patient needs rate control or rhythm control. So first of all, I need to identify and treat the reversible causes. Whatever the cause was should be treated as much as it can be done. So after that, we're going to think, what am I going to do to the patient next? Am I going to go for rate control or rhythm control? Most patients need rate control and rhythm control together. So baseline, we need to control the rate. because it's not acceptable and cannot be tolerated for a long time that the patient is having heart rate above 100. Heart rate should be less than that. So we go for the rate control, and then we can add the rhythm control above that, or it cannot be added if the patient doesn't tolerate rhythm control. So rate control, that's going to be by beta blockers, calcium channel blockers. Sometimes if the patient is having any structural heart disease, we might go for amiodarone or digoxin. Regarding rhythm control, again, we can go for the amiodarone, we can go for the other antiarrhythmics like the flecainide. But in both cases, if I decided to go for rate control or for rhythm control, I should put on my mind that full anticoagulation with low molecular weight heparin or with any type of anticoagulation to keep the window open for cardioversion. Because now I'm talking about the patient who is having atrial fibrillation for less than 2 days. This is acute atrial fibrillation. We can go for cardioversion and stop the patient from having treatments for life. Previously, we used to anticoagulate the patient for 3 weeks before the electrical cardioversion and then 4 weeks after. Now we can go for another approach. Even the patient can have transesophageal echo. And if it's proved that the left atrium specifically and all the heart doesn't have any thrombus, we can go for immediate anticoagulation for the same day and cardioversion the next day, and then anticoagulation for the next 4 weeks. So the 4 weeks post cardioversion are there for all patients. The 3 weeks pre to cardioversion, we can just overcome them by having transesophageal echo and making sure that the patient doesn't have any thrombus. So if I found any patient who is having atrial fibrillation less than 48 hours and the patient is hemodynamically stable, my aims are to control the rate, because to decrease the heart rate from 100 is going to help the patient, and to prevent adverse effects of having tachycardia for a long time. One of them is heart failure. And then after controlling the rate, I will think about restoring the rhythm to the normal to stop this patient from having medications for life. The rhythm can be restored by chemical pharmacological cardioversion or by electrical cardioversion. In both cases, and electrical cardioversion is preferred, by the way. And in both cases, if I decided to go for chemical or electrical, I need to anticoagulate the patient before and after. Before that can be 3 weeks, or I can overcome the 3 weeks if I decided to go for transesophageal echo, and after it should be for 4 weeks. And the third category, this is the most common type of patients that we face in our medical practice. When we have a patient who is having atrial fibrillation for an unknown duration, the patient presents and is found to have atrial fibrillation. Nobody can have a clue when this developed, even if the patient presents with acute infection, now pneumonia, or thyrotoxicosis, or pulmonary embolism, or even if the patient presents with heart attack, whatever the risk factors are associated with that, we don't have any clue. So we are going to deal with this as chronic atrial fibrillation. Main goals of treating chronic atrial fibrillation is the rate control and anticoagulation. Atrial fibrillation by itself is not a necessity to have anticoagulation for life, but we need to look for other indications for anticoagulation when the patient is having atrial fibrillation, which are the CHADS, VASC score. But unfortunately, the CHADS is going to be positive in almost more than 95% of patients. So as soon as the patient is diagnosed with atrial fibrillation, beta blockers should be given, or calcium channel blockers, or digoxin if the patient is having a sedentary lifestyle. So main aims of treatment here are to control the rate and to anticoagulate. Rate control, beta, calcium channel blockers, or digoxin if the patient sedentary lifestyle. Anticoagulation depends upon the score of the patient on CHADS VASC score. Does the patient has congestive heart failure, heart hypertension? Age of the patient will be 1 or 2 points. If 65 to 74, it's going to be 1 point. 75 and above, it's going to be 2 points. Diabetes and stroke or TIA in the past will have 2 points. and VASC or the peripheral vascular disease. Any point of those, if anyone is positive, then the patient is deemed for anticoagulation. So as soon as I'm faced by a patient who is having atrial fibrillation for unknown duration, this is going to be chronic atrial fibrillation. Goals of treatment are beta blockers and anticoagulation if any of the CHADS VASC score is positive. There is again a window for rhythm control. This is usually, for example, if the patient is having congestive heart failure, because it's going to be of very good yield for patients of congestive heart failure to control their heart failure itself. So why not to give it a trial? If it's effective, that's going to help the patient a lot. If it's not effective, we will go back to the rate control, and that's going to be the management. Again, if the patient is young, just to avoid giving the patient medications for life and to avoid all the risks associated with having anticoagulation for life. First presentation, or if there is a known cause, for example, electrolyte imbalance for a certain period, for a certain duration of time, if there is a clear cause that is caused the atrial fibrillation to happen to the patient, so definitely I will control the rate. I will think of rhythm control, give it a trial, and if it's effective, that's going to help the patient. Again, it's going to be pharmacological, biflecainide or amiodarone, or electrical cardioversion. The same rule applies here too. There's going to be 3 weeks before cardioversion and then 4 weeks after anticoagulation. The 3 weeks again can be overcome by doing the transesophageal echo to rule out any heart thrombus. If there is no thrombus, we can anticoagulate today, tomorrow cardiovert, then continue anticoagulation for another 4 weeks, and that is it. Last thing, just few words about frequent paroxysms, or if there is a known trigger for the patient to have atrial fibrillation. Some patients will have pill in the pocket. It's a tablet of sotalol or flecainide, which is going to rhythm control immediately. Some patients are young and their CHADS VASC score is negative and they have paroxysmal atrial fibrillation, and by the time they know what brings the atrial fibrillation for them. Those patients usually come to the clinic and they are investigated by 48 or 72-hour tapes, Holter monitor, and it's proved that they have atrial fibrillation. The best option to treat them is to give them the pill in the pocket. They are usually counseled to keep this pill with them all the time under any circumstances, even if they are going to the bathroom. During sleep, it should be upon their reach, at work, all the time. And then they are free to take it whenever they have the attack, until they go for the next step, which is to control the rhythm by having radiofrequency ablation, cryotherapy, or laser balloon ablation. So it's the step of the pill on the pocket is just a transit step until they are prepared for the surgery for the radiofrequency ablation. This is for the young who are CHAD negative and who have a known trigger for their atrial fibrillation. I hope it's clear so far.
Yeah, it is. Shall we open the discussion, allow the attendees to have questions if they have? Is that okay?
Yes. Yeah, I'm ready to answer the questions, and if they want me just to repeat that in the management in a quick way, I'm ready to. So.
Right. Anybody with questions, guys? Anybody want to repeat anything which is unclear for them? Okay. I've got a question.
Yeah.
Actually, one of my friends had this question, and it was a bit tricky. So in the permanent AF, which has been rhythm controlled back to sinus rhythm, the anticoagulation is just 4 weeks after the cardioversion.
Yes.
True. If there was any paroxysmal attacks in between, we will have to restart the anticoagulation again.
Again.
Yeah.
So, for example, if the patient is cardioverted on the 2nd of June, so this patient needs to be on anticoagulation whatever type of it, target INR 2 to 3, from the 2nd of June till the 30th of June. And they usually come to the clinic to have ECG weekly. And they are told and informed clearly that if they have any symptoms of atrial fibrillation, of palpitation, just try to come as soon as you can. At this time, if at any point, for example, on the 10th of June, they developed another attack of atrial fibrillation, it's going to be a new anticoagulation from the 10th of June.
Okay. And in this case, probably it will be, carry on.
And at this time, we are going to change the management from permanent atrial fibrillation to paroxysmal atrial fibrillation. Again, if there is a trigger known, we will try to manage the trigger. If there is no trigger known, this is going to be failed cardioversion, and the patient is going to be on anticoagulation and rate control for life.
Okay. Yeah, that makes sense.
Okay.
Thanks, Rawia. Anybody has any question, guys? Any comments before we close? Well, that's a good sign.
Okay. Okay. I hope everybody now get it clear, and I hope everybody just get benefit from what we have been talking. But take home message: atrial fibrillation, rate control, anticoagulation. There is no issues of trying a rhythm control if the patient is young or if the patient is having heart failure. Most of the time, it's not going to be effective. Almost all patients end up of having bisoprolol and anticoagulation for life.
Yeah, that was a good stepwise approach and summary for all types of AF that anybody can face. And if you don't mind, you can share the slides on the group as well. I think many of us would like to review this every now and then whenever they face a patient with atrial fibrillation.
Yeah, sure, no problem at all.
Thank you so much, Rawia, for being with us today and for this interesting topic and very hot topic for medical, and I think for surgical people as well. They have so many people in surgical wards having AF. Well, they will call you for that, I know. So
yeah, the Madrid.
Thank you.
Thank you everybody for being with us this evening, and as I said, the recording hopefully will be on the group by tomorrow with the feedback form, inshallah. I hope to see you all next Friday, and have a nice week.
Thank you.
Thank you very much.
Have a nice week. Thank you.
Thanks.
Thank you very much.
Assalamu alaikum.
Bye. Wa alaikum assalam wa rahmatullahi ta'ala.